This module covers female hormones and reproductive physiology. Menarche is the onset of menstruation. Guyton specifically calls this the female sexual cycle because it involves both the ovarian cycle and uterine cycle. As a female approaches puberty, about 9 years old, the hypothalamus will begin to progressively release more and more gonadotropin-releasing hormone, which increases the production of follicle-stimulating hormone and luteinizing hormone by the anterior pituitary, which leads to the onset of menarche. It actually takes about 3 years of this process of gradually increasing the FSH and LH before menarche actually begins. Menarche is affected by leptin. Prepubescent increased secretion of gonadotropin-releasing hormone is affected by leptin levels in the female. Leptin is a hormone produced by adipocytes. Low levels of leptin will delay puberty. Therefore, if a young female is extremely lean, her onset of menarche may be later in years. And on the other hand, high levels of leptin can stimulate early onset of menarche. Therefore, a obese or very heavy-set young female may start their menarche at a much earlier age. Of course, the mother's age will also have an effect or factor on the onset. And the research that I did prior to coming to here, I was researching young girls between the ages of 8 and 12, and many of the young girls, 9 and 10, had already started menarche, and these young ladies were quite obese. The menstrual cycle or female sexual cycle. As I mentioned before, Guyton refers to it as the female sexual cycle because it contains 2 distinct cycles, the ovarian cycle and uterine cycle. However, the menstrual cycle is a more common term, and it's even used by endocrinologists and the medical community. So I will most likely refer to it as the menstrual cycle from this point forward. Also, if a female is tracking her cycle, the tracking will begin day 1 of the first spotting of blood of the menstrual cycle. So it really makes more sense to call it the menstrual cycle. This cycle, on average, occurs every 28 days. Again, that is just an average. A menstrual cycle occurring every 21 days to every 35 days is considered normal. If it's less than 25 days, it would be classified as polymenorrhea. And if it's more than every 35 days, it would be considered oligomenorrhea. And if a woman just doesn't have a period at all, it's amenorrhea. This cycle, the menstrual cycle, includes 2 significant events and 2 cycles. Maturation or maturing of a single oocyte into an ovum occurs during the ovarian cycle, and the preparation of the endometrium for implantation occurs during the uterine cycle. Oogenesis is the production of an ovum, and it begins in utero, meaning the female embryo, while she is developing, her ovaries are going through at least meiosis 1 of the process of oogenesis. Oocytes grow from stem cells or gametes called oogonia. And as I mentioned before, these oogonia will grow up to the primary oocyte stage and then remain in that suspended animation until puberty. After the onset of puberty, the ovaries will undergo a monthly cycle, about monthly, where the follicles inside the ovary matures a primary oocyte into a secondary oocyte. This stage is called the follicular phase of the ovarian cycle. The secondary oocyte will be released by the ovaries at the end of the follicular cycle by an event called ovulation. In utero, around weeks 4 to 5, the female embryo's genital ridge will begin to secrete estrogen. This will cause female sex characteristics to begin to develop. The gonads will begin to differentiate into ovaries. If you remember, in the male embryo, their genital ridge will start to secrete testosterone around this age to differentiate the gonads into testicles. Around week 6 to 8, the primordial germ cells grow and differentiate into oogonia, and then meiosis 1 phase of oogenesis will begin in earnest. Fate of oogonia. Some oogonia differentiate into a primary oocyte or primary follicle. I will use those terms interchangeably in this lecture because a follicle matures an oocyte. So if I were to say a primary follicle, you would understand that it contains a primary oocyte. If an oogonium is surrounded by a primary follicle cells, it will grow and become a primary oocyte inside the primary follicle during meiosis 1 inside the developing ovaries in the female embryo. This primary follicle or primary oocyte will remain suspended in prophase 1 until puberty. Some oogonia in the developing females or ovaries will not differentiate into primary oocytes and follicles. If an oogonium is not surrounded by primordial follicles, it dies. Fate of oogonia continued. Most oogonia have degenerated by birth. A female baby is born with her lifetime or presumed lifetime supply of primary oocytes. And the reason I say presumed, because in my research that I did prior to coming to Sherman, they were able to stimulate some new supply of primary oocytes in females with fertility medications. Degeneration of the oogonia will continue after birth. By puberty, only about 400,000 survive. If you look at this diagram, you can see in the first trimester, actually by that first trimester, there's almost 700,000 oogonias. So we need to have that process of atresia, shrinking some of them so that they don't all become primary oocytes, because 400,000 primary oocytes is really plenty for a female to have in her lifetime. The female reproductive cycle involves two main cycles, the ovarian cycle and the uterine cycle. The ovarian cycle controls the uterine cycle. There are three phases to the ovarian cycle: the follicular phase, ovulation, and luteal phase. During the follicular phase, a follicle develops an oocyte and produces a lot of estrogen. During ovulation, which is more accurate to call it an event, the mature secondary oocyte is released due to a surge in LH, high estrogen levels, and high FSH levels. During the luteal phase, the empty follicle, which now develops into a corpus luteum, is producing progesterone as well as estrogen. I want you to hang on to the fact that there's no progesterone produced during the follicular phase. It's only after ovulation do the ovaries produce progesterone. The follicular phase. This begins with the anterior pituitary increasing secretion of FSH and then a few days later LH. This timing is extremely important to normal physiology of the ovarian cycle. The secretion of FSH is slightly higher than that of LH, which is also extremely important to the normal physiology of the ovarian cycle. This will increase or accelerate the growth of 6 to 12 primary follicles each month. Follicular phase formation of a follicle. If you look to the diagram on the right, you'll see at the top a primary oocyte within a primary follicle. If you remember, this is where it has the primordial follicular cells surrounding it, and also has a basement membrane at this point. During the follicular phase of the ovarian cycle, granulosa cells will proliferate around this primordial follicle, or primary follicle, Then after there has been several layers of these granulosa cells, because if you look at the bottom, it becomes striated, so there's several layers of it. Another cell, a new cell called spindle cells, will collect outside of the granulosa cells, and these cells will become a new cell mass called theca, or the theca layer. The granulosa cells are separated from the theca cells by a basement membrane. At the same time, the oocyte will secrete a glyco-rich protein substance that encapsulate it called the zona pellucida. This is the layer that the sperm cells must penetrate in order to facilitate fertilization of the secondary oocyte. Follicular phase formation of estrogen. Theca cells stimulated by LH produce androgens that diffuse through the basement membrane into the granulosa cells, and then the granulosa cells stimulated by FSH convert the androgens into estrogen. Now you can see here if there was any problems with the timing and the secretion of FSH, which I mentioned earlier must be secreted a few days before and at a higher amount than the LH, then the granulosa cells would not be able to convert the androgens into estrogen. And any excess androgens in the female ovaries will be converted into testosterone, and then this could lead to problems. The next statement is going to be just FYI, so if you are not interested in hearing about polycystic ovarian syndrome, you can go on to the next slide. But prior to coming to Sherman to teach, I worked for the University of Virginia School of Medicine Department of Endocrinology, researching polycystic ovarian syndrome. Again, this following information is presented just because, unfortunately, you will have patients with this condition. It is pretty prevalent. The main hormonal problem with PCOS is abnormal levels of certain hormones or the abnormal timing of when certain hormones are released. One example of a hormonal problem associated with PCOS is the abnormal secretion of LH. For example, if a female secretes high levels of LH, luteinizing hormone, it will cause the theca cells to produce more androgens than the granulosa cells can convert into estrogen, and the excess androgens will be converted into testosterone. Or if a female secretes a normal amount of LH, but it secretes it before FSH is secreted, then the granulosa cells will not be able to convert the androgens produced by the theca cells into estrogen, and those androgens will be converted into testosterone. Excess testosterone coupled with low estrogen can cause hirsutism, which is facial hair in a female, and infertility as well. Women with PCOS are also in danger of high blood pressure, obesity, and diabetes. These additional reactive conditions to PCOS may be due to whatever is causing the abnormal secretion of the LH. This is just one area being investigated. Abnormal functioning of the adrenal gland, which also produces androgens, is also being investigated as a cause of PCOS. I also neglected to mention in the adrenal PowerPoint that Cushing's syndrome can also lead to PCOS, mainly because Cushing's syndrome is hyperadrenalism, which is going to secrete way too many androgens. And if you have hypersecretion of adrenal cortex hormones, that will lead to high blood pressure and diabetes. Follicular phase formation of an antrum. Typically, one follicle will take the larger share of FSH and LH being secreted. This will allow that one follicle to develop the primary oocyte into a secondary oocyte. The granulosa cells in this follicle will begin to secrete a fluid high in estrogen. The accumulation of this fluid causes an antrum to appear within the masses of the granulosa cells. Follicular phase formation of a vesicular follicle. The fluid-filled antrum continues to expand and become a vesicular follicle. As the follicle grows, the oocyte also grows and matures into an ovum. Once the follicle has gotten to this fascicular stage where it's almost all fluid within the center, it is very close to ovulation. Follicular phase atresia of follicles. The follicles that did not form an antrum will undergo a process called atresia or shrink. Atresia is designed to prevent more than one child being developed with each pregnancy. The follicular phase just prior to ovulation. The estrogen in the antrum fluid reaches a high enough concentration to cause granulosa cells to make LH receptors. Now, LH can bind to these granulosa cells. Granulosa cells stimulated by LH begin producing and secreting progesterone. Progesterone has pyogenic effects, meaning that the basal body temperature of the female will increase 1 to 2 days prior to ovulation. This allows a female to chart about when ovulation will occur. Ovulation occurs midpoint of the menstrual cycle, about day 14 if we're using 28 days as a typical length of a cycle. LH secretion increases about 2 days prior to ovulation. This will stimulate both the granulosa cells and the thecal cells to produce mainly progesterone. And as I mentioned before, progesterone will increase the body temperature of the female, allowing her to track when ovulation will occur. Ovulation is stimulated by a surge in both LH and FSH. More LH than FSH is necessary. The LH surge causes the follicle to reach the surface of the ovary, rupture the follicle membrane, and release the egg. Without LH surge, ovulation will not occur, even if there's adequate amount of FSH. I want to draw your attention to the chart, and you can see a huge surge in the LH. That's why appropriate amount and timing of certain hormones are critical in the female reproductive cycle. Not all menstrual cycles are ovulatory. It's not abnormal for a female to have 2 or 3 non-ovulatory cycles per year. However, more than that would be suspicious of a polycystic ovarian syndrome. So it's key to have plenty of LH surge. If a woman does not have ovulation during a cycle, it will affect the timing of the sloughing off of the endometrium, which is during the menstrual phase of the uterine cycle, and it will offset the timing of her period, and it will take time to re-regulate it. Chiropractic care is amazing in this type of situation. If a female has a subluxation, typically in the lumbar or sacral area, and they are their period is offset, and they know they feel the fullness, they know they need to have their period start, they know they're not pregnant. And if you give them an adjustment, they could start their period within seconds. So be prepared. I had that happen to me once and I wasn't prepared. And I had to loan the young lady some clothing to get home. So be prepared how powerful chiropractic is in maintaining regulation of a female's reproductive cycle. The luteal phase formation of the corpus luteum. So after ovulation, we are now into the luteal phase. After ovulation, the granulosa cells and theca cells of the empty follicle differentiate into what's called lutein cells. They grow and fill with yellow lipids, a process called luteinization, and form a structure called the corpus luteum. Luteinization allows these cells to produce progesterone and estrogen without FSH stimulation. Luteal phase negative feedback. The corpus luteum secretes large amounts of progesterone and estrogen during this phase, more progesterone than estrogen. The estrogen secreted by the corpus luteum has a strong negative feedback on the anterior pituitary, maintaining low levels of FSH. The luteinized granulosa cells secrete a small amount of another hormone called inhibin, very similar to the Sortelli cells in the testicles. And this inhibin will have a strong influence on the anterior pituitary, inhibiting it from secreting FSH. Why is this so important? This is important because if FSH and LH were to be secreted in the luteal phase, it would actually initiate the follicular phase of maturing an ovum, and it would mess up the whole system because you don't want a new egg being matured while the body is hoping the one that just got released will get fertilized and implanted. So it's very important that this negative feedback system is functioning properly. The luteal phase formation of the corpus albicans. If pregnancy does not occur, the low levels of FSH and LH will cause the corpus luteum to eventually degenerate after about 10 days, becoming a scar called the corpus albicans. Implantation of an embryo. If pregnancy does occur, embryonic tissues will secrete another hormone called human chorionic gonadotropin. That's actually the hormone that is detected on the pregnancy urine sticks. This will prevent the degeneration of the corpus luteum and stimulates it to produce large quantities of progesterone and estrogen until the placenta is developed enough and will take over that role. Once the placenta starts to develop the needed amounts of estrogen and progesterone and human chorionic gonadotropin and another human chorionic somatomatotropic, then the corpus luteum will become the corpus albicans. The uterine cycle involves cyclic changes of the endometrium of the uterus. It is directly regulated by the ovarian cycle's production of estrogen and progesterone. It has 3 phases: menstrual, proliferative, and secretory. The menstrual phase corresponds to the onset of the follicular phase in the ovarian cycle. During the menstrual phase, the endometrium of the uterus lining sloughs off. Following the menstrual phase is the proliferative phase, and that's where the endometrium starts to rebuild itself again, and it begins thickening. Following the proliferative phase comes the secretory phase, which also occurs right after ovulation of the ovaries. During the secretory phase, the endometrium can double or even triple in size as it is preparing itself to receive an embryo. The menstrual phase. Before I get into more details of the different phases of the uterine cycle, I want to draw your attention to the chart on the right. Board questions often ask how or what phase of the ovarian cycle affects the uterine cycle. They want you to understand the correlation of what's going on in the uterus and what's going on in the ovaries at the same time. I found this to be one of the better charts that helps to show the correlation between these two cycles and how the ovarian affects the uterine cycle. During the menstrual phase, if you look on the chart, you'll see that that's occurring right at the same time as the onset of the follicular phase, when all the hormones are low. FSH, LH, estrogen, and progesterone are extremely low at this beginning of the follicular phase. That's because, in this case, there was no implantation. If there was implantation, these hormones would be high. But once there's no implantation, the hormones drop way low, and that causes the uterus to shed all but its deepest layer of the endometrium. During the proliferative phase, estrogen levels begin to rise. If you look in the chart, you can see that the proliferative phase immediately follows the menstrual phase, and is still correlating with the follicular phase of the ovarian cycle. This estrogen stimulates the endometrium to rebuild. It also thins the mucus plug that is in the uterus to facilitate sperm passage into the uterus. Ovulation will signal the end of this phase. The secretory phase, also known as the post-ovulatory phase, because it occurs immediately after ovulation and corresponds with the luteal phase of the ovarian cycle. During this phase, this is now when the ovaries start to produce progesterone. They do not produce any progesterone during the follicular phase. So now we have two hormones being produced by the ovaries in the secretory phase. Both progesterone and estrogen levels will rise from the corpus luteum. This is going to stimulate formation of spiral arteries preparing the endometrium for implantation. Again, this is where the endometrium can double or triple in size, and these spiral arteries are key to providing nutrients to the implanted embryo for its survival. Also, during the secretory phase, the mucus plug begins to thicken in the cervix. This is to seal off the uterus and trap bacteria to provide a sterile environment to protect the embryo in the event there is fertilization. I have on here also that it inhibits LH release. The secretory phase doesn't actually inhibit LH release. It is the high levels of progesterone and estrogen being produced by the corpus luteum corresponding to the secretory phase that actually inhibits LH and FSH release. No implantation, the cycle repeats. Towards the very end of the secretory phase, the spiral arteries go through a cyclic type of intermittent vasoconstriction and vasodilation, back and forth. However, if implantation does not occur, the spiral arteries will constrict one final time, then suddenly relax and open wide. The gush of blood fractures the weakened capillary beds, causing the endometrium layer to slough off, and then the cycle will start all over again. Estrogen. 3 types are present in plasma if you were to take a blood sample. B estradiol is the main estrogen produced by the ovaries. And when people or doctors are referring to the estrogen levels of a female during the reproductive years, this is the type of estrogen they're really referring to. B estradiol is 12 times more potent than estrone and 80 times more potent than estriol. Estrone is produced by the adrenal cortex throughout life. That is the estrone that's produced from the androgens produced by the adrenal cortex. It is also produced by theca cells during the menopausal years of females. Estriol is a very weak oxidative product derived from both estradiol and estrone. The primary function of estrogen: it promotes oogenesis and follicular growth in the ovaries, and develops and maintains primary sex characteristics in the female. Functions and effects of estrogen. Estrogen in the female is analogous to testosterone in the male in that estrogen is responsible for the primary sex characteristics of a female. It increases the size of the female internal and external sex organ. It thickens the vaginal epithelium, which is critical for vaginal birth. It also increases the ciliated epithelial cells of the fallopian tubes, which is necessary to sweep an ovum towards the uterus for implantation. Estrogen also plays a role in the secondary sex characteristics of a female. It plays a role in the body hair distribution of females. It initiates the growth of primordial breast. It develops the stroma of the breast tissue, which is the framework of the breast, and it is responsible for the growth of the milk-producing duct system in the breast. It plays a role in the deposition of subcutaneous fat in breast and hips that are characteristic of the female figure. And it is responsible for the development of the wider pelvis, which is necessary to facilitate vaginal birth, and a lighter pelvis as well. Metabolic effects of estrogen. Estrogen maintains low total blood cholesterol. It promotes high-density lipoprotein transport and interferes with low-density lipoprotein transport in the blood. It reduces atherosclerosis, therefore it helps to reduce cardiovascular disease. It increases calcium absorption, which will aid in increasing or maintaining bone density, and it causes sodium and water retention in the kidney tubules. So if a woman in her reproductive years feels bloated and it's during the follicular phase of her cycle, she actually is. Estrogen's effect on bone. It inhibits osteoclast activity. This combined with increased calcium absorption will strengthen bone. It also stimulates bone growth, along with growth hormone and thyroid hormone. It determines the length of bones and is responsible for closure of the epiphyseal plates in long bones. Effects of estrogen on skin. Estrogen causes a soft, smooth texture of skin. It increases the thickness of skin, mostly the hypodermis or subcutaneous layer. It also increases vascularity of skin, so it's responsible for increased warmth, particularly during the follicular phase when estrogen is highest. And it is also responsible for bruising during that phase. The individuals will be more susceptible to being bruised when their estrogen levels are high. Progesterone. There's two types of progesterones found in plasma. One is progesterone, which is the largest and most important of the progesterones, and 17-alpha-hydroxyprogesterone. Effects of progesterone on the uterus. Primarily, that's all progesterone does, is something to do with the uterus. It primarily affects the uterus by promoting secretory changes of the endometrium during the luteal phase of the uterine cycle, and it maintains the endometrium in the event there's implantation. Progesterone decreases the frequency and intensity of uterine contractions. Remember when we were talking about the effects of prostaglandins and how it reverses peristalsis of the uterus so it could facilitate the sperm getting to the egg? Well, progesterone also decreases these uterine contractions so that it prevents the uterus from expelling an implanted fertilized zygote. It promotes also mucus secretions in the uterus so that it can provide nutrients to the developing embryo. Effects of progesterone on fallopian tubes. It promotes increased mucus secretion in the fallopian tubes to provide nutrition to the developing fertilized embryo as it travels to the uterus. Effects of progesterone on breasts. Progesterone promotes breast development of the lobules and alveoli. It causes the alveoli cells to grow, divide, and become secretory. It does not stimulate milk production. Milk production is stimulated by another hormone called prolactin. Placenta hormones. There's several, but I'm just going to talk about the four main ones produced during pregnancy. Estrogen, progesterone, human chorionic gonadotropin, and human chorionic somatomammatropin. Effects of placenta progesterone. It's basically exactly the same effects that progesterone from the ovaries have on the uterus. It causes specialized cells to grow in the endometrium that provide nutrition for the embryo. It decreases the frequency and intensity of the uterine contractions to prevent expelling the implanted embryo. It promotes secretion of the uterine and fallopian tube mucosa to provide nutrition to the developing embryo, and it helps to prepare the breast for lactation, again with the help of estrogen. Effects of human chorionic gonadotropin and human chorionic somatomammatropin. Human chorionic gonadotropin primarily promotes placental development. It is essential for the placenta to grow and be maintained. Human chorionic somatomammotropin has a function very similar to growth hormone, yet all of its properties are not quite understood yet. And it is too much of this hormone that leads to gestational diabetes. Lactation. Day 1 to 3 after birth, the breasts produce a product called colostrum. It is yellowish, has less lactose and almost no fat in it compared to true milk. It contains more protein, vitamin A, and minerals than true milk does. It contains immunoglobulin A antibodies, neutrophils, and macrophages passed on from the mom to help the baby fight any infections until the baby's immune system kicks in. After day 3, true milk begins to produce, and suckling will stimulate the prolactin release along with oxytocin, which allows the letdown. And as long as there is a baby suckling, the female will be able to produce milk.